Hello everyone, my name is Nicole Larm, and for this presentation, I've decided to explore the health belief model. The health belief model that you'll see commonly abbreviated in this presentation as HBM was one of the first theories of health behavior to be developed. In the 1950s, a number of social psychologists like Hochbaum and Rosenstock worked to develop this model in order to explain the lack of participation from individuals in public health programs. One of the programs mentioned was a preventive program being offered for free with convenient locations for x-rays for tuberculosis screening. People weren't really taking advantage of this free health screening, which led people to ask why. It was proposed that people's beliefs about whether they are susceptible to the disease in question, their perceptions of the benefits of avoiding the disease, these both influenced if they were going to act on this health behavior of getting screened. On this slide, I wanted to take a moment to present the infographic that I made. It's a little zoomed out, so I'm going to proceed to the next slide where you could see a more zoomed in version. Now that we can see this infographic a little bit better, we can see that this demonstrates a more updated version of the health belief model, which has evolved throughout the years. And this focus is really placed on perceived threat and perceived benefits, which is much more encompassing. This model illustrates the relationship between health and individual beliefs. The health belief model attempts to explain or predict health behaviors based on modifying factors, individual beliefs, and cues to action. Modifying factors can be something like age, sex, ethnicity, education, personality. These are really factors that are considered to influence someone's beliefs, which will ultimately lead to whether a person decides to act. Now, one of the major constructs of this model are individual beliefs. That includes perceived susceptibility and perceived severity, which are how likely someone is to be affected by the health condition, meaning susceptibility, or how serious it would be if they were affected, meaning severity. Now, these both are thought to make up the greater concept of perceived threat, and the greater the threat is, the more likely the individual is to act. More individual belief constructs are self-efficacy and perceived benefits compared to perceived barriers. This means, does the individual believe they can overcome the challenging question? And then as far as perceived benefits and perceived barriers, the individual considers whether the rewards of the action compared to the challenges or barriers they face or might encounter, whether it's really worth the risk. Now we also have cues to action, which were added a little bit later on in the progression of this model. And it's typically a prompt or reminder that urges someone to act. So this could be something like a phone call, reminding someone to schedule a dentist appointment. It could be signs with the COVID-19 grocery stores reminding people to social distance. It could be signs in the bathroom reminding people to wash their hands. It's really something that kind of prompts someone to act. And if we use our team, that's how we believe the action is. The first case study I wanted to explore is titled Community Pharmacists and Communication in the Time of COVID-19. This applies the health belief model, and I thought this was a great example because of how recent it is. In this article, when the rapid onset of COVID-19 started happening, public health officials were looking for a quick way to spread information until formal toolkits of information could be created and brought out by the public. The need arose to share information on how to stop the spread of COVID-19. Local community pharmacists were called upon to spread these mitigation practices because they were thought to be a good option for local community interactions with the public. This article considered modifying factors like socioeconomic standings. So if people with a lower socioeconomic standing may not have had the tools needed to overcome these perceived barriers. Different ethnic backgrounds, like if someone had cultural attitudes or norms surrounding their culture that may interfere with social distancing, that may be considered. And it's thought that a community pharmacist has a better understanding of these factors because they're such a part of the community. The next major leg of the health belief model, we explore perceived susceptibility, perceived severity, and perceived threat in the situation. So it was important for pharmacists to convey a severe threat to the elderly and those with underlying conditions, but in a way that wouldn't let younger people think they were safe. We're completely safe from COVID-19 because, as we know, it is a disease that affects everyone. As far as perceived benefits, it's important to know the to assess benefits of staying home. For example, they could include questions like, are there benefits of spending more time at home? And what could those be for you? What are some things you have wanted to do around the house but haven't had time for? What hobbies haven't you had time for? Things like that could show the benefits of someone staying home in a time of self-quarantine. Then there are perceived barriers that might be harder to overcome or harder for a pharmacist to show how to overcome. For instance, it could be income that's needed per household that wouldn't be allowed if they were to stay home. There could be worries about self-distancing in heavy populated areas. And being too afraid of the disease itself could also present as a barrier. Then for perceived self-efficacy, it's important to listen to the concerns and then reinforce in positive steps. For example, if someone's afraid of coming out to receive their medicine, the pharmacist could push for mail order refills or something like minimal contact solutions and methods created in the time of COVID-19. Cues to action would also play a role in this case study. In a community pharmacy, something like reminders of social distancing while standing in line, or advising those who are exhibiting symptoms to self-quarantine also play a role in this model. While this case study was effective at applying the health belief model, it had some pros as well as some cons. For instance, this was a quick and cost-effective way to spread the appropriate information to local communities. However, during this pandemic, information continued to change. Also, because it was spread at such a local community level, not everyone will interact with their pharmacist. However, a pro would be the high-risk patients may frequent the pharmacy to get medications they often need, so the people most in need may be warned in time. For my second case study, the article was titled, Effects of Education Based on Health Belief Model on Dietary Behaviors of Iranian Pregnant Women. This article examined how effective applying the health belief model would be to affecting dietary behaviors of pregnant Iranian women. In order to prevent low birth weight of infants, it's important that the mother's nutrition is sufficient. Something this article did very well was narrow in on their target population. Many of the health behavioral theories stress that too broad of a population will diminish the effects of the applied theory. This case is specifically looking at low-risk pregnant women living in Tehran, and the mean age was roughly 26 years old. For this study, a questionnaire was created based on the health belief model, and then 2 training classes spaced 1 week apart were conducted. The questionnaire consisted of questions that touched upon major constructs of the health belief model. For instance, for knowledge, what is the minimal amount of fruits and vegetables that should be consumed during pregnancy? For perceived susceptibility, because I've never had nutritional problems during pregnancy, therefore it will not happen to me. Perceived severity was, nutritional problems in pregnancy can cause dire consequences for mother and baby. For perceived benefits, recommendations and presentations about nutrition during pregnancy will lead to a healthy baby. For perceived barriers, preparing the required foods during pregnancy should take a lot of time. And then for cues of action, we have family members and my husband are recommending that I pay attention to nutrition for pregnancy. There was also a question about dietary behaviors, which stated, how much dairy and milk products do you consume? Each of these questions was centered around one of the major concepts of the health belief theory. The results of this study indicated that nutritional prenatal care and proper knowledge is needed for pregnant women. They also need to be educated about the severity of risks associated. For behavior modifications, sufficient motivation seems to be required. As far as knowledge, perceived benefits, and the perceived severity are needed to modify dietary behaviors, and perceived barriers need to be decreased in order to see this action changed. Usually, pregnancy care practices should be combined with the health belief model in a healthcare setting, which was the ultimate conclusion. Now let's discuss the pros and cons for the second case study. So again, a pro of the health belief model is it is a quick and cost-effective way to spread appropriate information. And for this specific case study, the specific target group allowed for consistent modifying factors and less variables along the way. However, for the cons, I couldn't help but notice a gap between study time and what to expect in a real world setting. Pregnant women are not likely to sign up for several classes about nutrition, nor are these classes usually provided for free. the more likely result would be an informational pamphlet or online resources for the student. Also, the perceived barriers did not seem to be fully addressed in the study. The perceived barrier example, preparing food during pregnancy takes a lot of time. There was no specification on how this would be addressed, and this may not be the largest barrier for all pregnant women. By exploring the health belief model, I have noticed some overall limitations of the model itself. For example, it does not take into consideration intentions to perform the behavior and the social pressure that may exist around the behavior, like the theory of reasoned action does. Also, there's no specific ordering of the variables, but rather there are 6 independent predictors of behavior. It's hard to rank these constructs by most significant or most influential. Also, this is a static model, so meaning there's really no distinction between a motivational phase and how the behavioral change is achieved through planning action and maybe even the maintenance of behavior. However, it's always best to combine several models to achieve a health behavior. The health belief model is still a strong model. On this slide, you can find the citations for the multiple resources I used throughout this presentation. Thank you very much, and I look forward to your questions and comments.